Good morning, good afternoon, everyone. Welcome to this DCB Academy lesson on using physiology in left main PCI, which will be presented by Dr. Baharat from Singapore. Please, Dr. Baharat.
Thank you, Sarah, and it's quite a pleasure to be able to present this. I think it's quite an interesting topic, so hopefully I get to learn from some of you that may have experience with this, and I'm just sharing some of my experience. So the topic is using physiology in left main disease and left main PCI, and I think this is quite interesting. So we'll just get straight into it, and then we can discuss as we go along. So I just want to start off with a clinical case that I had 2 months ago now. So this was a 66-year-old lady. She had gone trekking in China and took a bus to 3,500 feet and then walked up to 6,000 feet, so a little mountain. When she reached 6,000 feet, she had chest discomfort, she felt dizzy, and she was short of breath. And she self-administered some supplemental oxygen, thinking it's mountain sickness. I don't know if very many of you have dealt with patients with mountain sickness, but she thought it was that and gave herself oxygen, and her symptoms seemed to improve. So she came back down and rested in a hotel, and a week later she returned home. And when she got home, her symptoms continued. So interestingly, she had progressive exertional dyspnea. She had dizziness, which was not vertiginous in nature, and seemed to be exertional related, and then ongoing chest heaviness. Of interest, she had no rest symptoms. So 2 days later, she came to the A&E. This is on a background of hypertension and hyperlipidemia, and she was previously fit and active. I mean, she used to go trekking quite often, and this was not an unusual trip for her to do. She's a non-smoker with no family history of heart disease, and this was her ECG on a right. So when we compared this to her prior ECG from 2022, that actually looked pretty normal. So you don't see those changes there. So these are new ECG changes. So she was admitted to the ward, and the attending thought, troponin negative, let's do a treadmill test for this lady. And so she ended up having a stress echocardiogram. She did 6 minutes and 53 seconds, 103 beats per minute, which was only 68% of her maximum predicted heart rate. And the test had to be stopped because she was breathless. She had these T wave inversions and developed some ectopics during exercise. But interestingly, she also had a significant drop in her blood pressure during peak exercise, so about 14 millimeters of mercury drop. So that's quite alarming. So they suggested that this was an inconclusive exercise stress echo for inducible ischemia, and that she had a significant drop in her blood pressure. So she came to the cath lab for an angiogram. This is the angiogram that I did. You can see the right coronary artery. She's got some mild disease in the proximal segment. It's a little bit calcified, but not flow limiting. And then this was her left system. So the LAD and the circumflex look okay. There's no, significant compromise there. But if you look at the ostial left main, it just looks a bit weird. And this is us kind of pulling the catheter back because when we engaged, there was some dampening of the catheter. So this is us pulling back and then taking the injections, and it just doesn't look quite right. So what's going on? We know that before I go on to show you, what we did in that case, we know that the left main supplies about 75% of the left ventricle, and an examination of 100 autopsy cases found that the left main had an average length of 10.8 plus minus 5.2 millimeters, and an average diameter of 4.9 plus minus 0.8 millimeters. So about 10 to 15 millimeters long and about 4.5 to 5 millimeters in diameter. And when we look at the parts of the left main, you've got the ostial, mid, and distal left main. And this is where atherosclerosis tends to occur. It tends to involve the lateral left main wall and extends into the side branches. Rarely, it can involve the ostial and mid shaft. And Prof. Cortese actually wrote this, made this next nice schematic where if you had a left main that was longer than 10 millimeters, it was more likely for you to have bifurcation disease, so disease at the bifurcation point. Whereas if you had a shorter left main, it tended to be ostial or mid-shaft disease. So that was quite interesting. So what is significant left main disease? Significant left main disease is found in about 3 to 7% of all patients that undergo angiograms. So, if you do 100 patients, 3 to 7 of those patients, you'll find left main disease. And it's defined as angiographically a more than 50% involvement of the diameter of the artery. And using IVUS criteria, we now have IVUS definitions that suggest that if it's more than 6 millimeters squared, it's acceptable to defer revasc. And in an Asian population, this level is actually slightly lower, and 4.5 millimeters square may be acceptable. So what about intermediate left main disease? So we're pretty confident with severe left main disease. So anything more than 70%, we can say it's severe, and we do offer these patients revascularization. But what about the moderate ones? The ones from about 40 to 60%? We're very bad at looking at these lesions angiographically. So there was this study that looked at how good are experienced interventional cardiologists at predicting functional significance of intermediate or equivocal left main disease, and 50% rates of misclassification means, flip of a coin. Half of them got them right, half of them got them wrong. Angiography alone misestimates the physiological severity when you use an FFR threshold of 0.8 in over 1/3 of angiographically intermediate. So if you're using FFR, we tend to misestimate the physiological severity in about 33%. And quite interestingly, the entire evidence base of left main management is based on visual estimates alone. The biggest trials looking at left main revascularization with PCI, Excel and Noble, really just based their decisions to revascularize on angiographic appearance alone. So this begs the question, we're so bad at angiography, does physiology have a role? Now, unfortunately, there's limited evidence of the use of physiology in left main disease because a lot of the large randomized controlled trials that have demonstrated the utility of FFR have excluded patients with left main disease. There is growing evidence from trials demonstrating improved outcomes using an FFR or IFR guided strategy versus angiography alone. For example, you've got the DEFER, the FAME2, DEFINE, FLAIR trial. But again, all of these have excluded left main disease. So what is the data that's available? So this meta-analysis looks at a few registry-based cohorts and summarizes the results from these registries, looking at the long-term outcomes in FFR-guided management of left main disease. And here we see that if you use a cutoff of 0.8 or below, you get equivalent outcomes in both groups, meaning that it's a feasible option. And particularly if you're getting a greater than 0.80 FFR, then it's safe to defer. And what is the correlation between IVUS and physiology? We know IVUS is validated, and these three studies actually looked at the best IVUS cutoffs to predict FFR significance. And these vary from about 4.5 in the Korean group to 5.9 in Justy's group, and so hence the 6 millimeter being used as the cutoff. What about FFR versus IFR? Now, there is some agreement that both FFR and IFR can be utilized. This study called the iLitro study actually compared FFR versus IFR FFR and IFR in 300 patients and compared that to IVUS and followed these patients up. And really what they saw there is that a physiology-guided treatment decision is feasible either with both FFR or IFR. And there is moderate concordance between both these indices. And in any case, if you do have a discordant result, then it's useful to use IVUS to then try and distinguish, whether the patient needs to undergo revascularization. So what does the guidelines show? Both the American and European guidelines actually do suggest the use of functional assessment, but unfortunately, this doesn't really apply to left main. For left main, they do consider using imaging and IVUS to help define lesion severity. The Europeans are a little bit more specific. They say that if you've got intermediate left main stenosis, the measurement of FFR and IFR should be considered, and that's a class 2A, level A recommendation. And that was on the most recent guidelines. So just some technical considerations when you are doing physiology in the left main. One thing you have to be wary of is that you can get pressure dampening, particularly if you've got variosteal or proximal shaft disease, and this can overestimate the FFR value. IV adenosine is the ideal hyperemic agent because it gives you time to disengage the guide. You don't have to inject anything down the coronary, with the fear of causing a hydrostatic dissection as well. And then finally, remember that left main lesions are rarely isolated, and these patients tend to have coexisting stenosis in both the LAD and the circumflex, and this can affect the FFR readings that you get. So Bill Ferron's group actually looked at this, and they showed that if you had downstream coronary artery disease, the FFR true may be different from the FFR epicardial as a result of this crosstalk between the two lesions. So what they suggest in their group is to try and do the FFR for the left main in the least diseased vessel. So for example, in the picture B, you've got some disease in both the left main and the LAD. When you measure the pressure or do the FFR across the LAD, you will get a falsely lower reading compared to when you do it in the circumflex, which is relatively free of disease. So they do recommend choosing a vessel that has minimal disease. And their conclusion was that the FFR true was statistically but clinically insignificantly lower than the FFR apparent. So meaning if you do the FFR of the left main using a vessel that has minimal disease, you're very close to the true FFR. And that was the recommendation there. So remember that both IVUS and pressure wire have their advantages and shortcomings. Both techniques are safe and effective to discriminate and help in clinical decision making. And there are times where it's not so uncommon to have to resort to the other technique for a more accurate assessment, where you just don't get the answer. So it's important to sometimes even consider both techniques. And this algorithm quite nicely tries to point that out. Most of the time, we try and use one modality if possible, just because it can become very expensive if you've got to use both IVUS and pressure wire. But if you are using IVUS and getting an intermediate IVUS MLA, particularly if you've got a patient from the Asian continent, and you're getting 4.5 to 6, then the recommendation is to then proceed with a functional wire assessment, either with FFR or IFR, and then determining revascularization based on that.
Well, sorry to interrupt. It's a very nice algorithm. It's also very important what you're writing here, which is always put data in context to symptoms. Because I have to be honest, if I have an area at IVUS which is 5.5, 5.4, 5, within this mid range, but the symptoms are consistent with ischemia, and I don't have a 90% stenosis of the right or the LAD or the circ, I in my normal case history, I would treat the left main. I have to say, if the symptoms are not clear, I agree that we should go with a further assessment with physiology. But if we have clear symptoms or electrocardiographic changes, I will go straight with the stent.
Yeah. Yeah, that's a very good point. So I was actually coming to that. So, whatever data you get, always put it in context of the patient, like Prof said. So if they have symptoms, if they got ECG changes, you've done a stress echo that suggests ischemia, and the patient's profile, then I think act on that. So don't just act on the number, put it in context of the patient, and then make your decision accordingly. There are some conditions where IVUS is probably a little bit better. So if you've got mid-shaft or distal, if you've got lesions in both the LAD and the circumflex, then you'll get crosstalk if you're doing physiology. And those that are pro FFR or IFR, particularly osteal left main, just because sometimes when you pull back the IVUS, you may not be able to catch the ostium per se. If there's a lot of scarring and there's the microcirculation is burnt out, then the physiology may not be as accurate. Or if you've got patients with very severe LV hypertrophy, things like hypertrophic cardiomyopathy, where you've got very thick muscle, then physiology may not be as accurate. And so, uh, just remember to think about the clinical context as well. So back to our patient, it was a decision of which one to use, whether we use IVUS or FFR. I like imaging, so I decided to proceed with IVUS.
Bharat, at this stage, I want to ask one thing more.
Yeah,
Sorry to interrupt you.
no problem.
Sometime we are discussing these cases with our cardiac surgeon, and surgeon, when we are our angiographically osteal left main disease is there, we are doing both FFR and IVUS for this case to conclude. But when we were discussing in our meeting with the surgeon, surgeon said no, angiographically it looks significant to me. We want more evaluation by CT scan and CT guided FFR. So can we compare these things with the CT guided FFR?
Yeah, I mean, I think CT guided FFR has been validated against invasive FFR. So, people talk about invasive FFR being the gold standard. I mean, I don't
Yeah.
really think it's the gold standard, but it's what we have.
Hmm.
And so I think if you've got an invasive FFR that's positive, you've got an IVUS MLA that's smaller than 6, and if you've got a patient with symptoms or demonstrable ischemia, I think that's enough. Um, I think the surgeons just want to be sure that if they're putting a lemur on, that the graph is not going to go down. Um, and I think there are some cases where imaging have been quite useful, where patients have had, for example, what appears to be osteal left main disease. You put the IVUS catheter down, and you can actually see the left atrium or the right atrium actually compressing on the osteal left main, and sometimes that's due to severe pulmonary hypertension. And in that situation, treating the pulmonary hypertension itself may be sufficient. So, there are some oddities in there, but for this case in particular, you can see there's arteriosclerosis. It extends back to the osteal left main here. And when we actually measured the osteal left main, we were getting a measurement of 5.38 with a 62% plaque burden. Now, remember, there was pressure dampening. She was a small Chinese lady. She wasn't very big size. And exactly for the reason that our surgeons may say that it's not, it doesn't angiographically look too significant, proceeded with a pressure wire assessment. Now, this is IV adenosine, and the resting indices 0.84 was positive, and then the FFR with IV adenosine was 0.79. And when you look at the pullback, so
So
I actually,
which is your course? Because if you have usually an RFR or IFR which is positive, we don't do adenosine.
the
So
other
why did
one.
you why did
Yeah,
you give
so I
adenosine
think,
here?
yeah, I think more for this, more for the completeness of getting the data. But if I do have a clearly positive RFR, then I tend to believe that. The only thing is, since some of the longer term outcome data from the IFR trials have come out, There's a little bit of noise about
Yeah, I understand. But if you have 88 or 87,
yeah,
I can understand. But
yeah.
or my question could be, okay, so why do you do RFR? If you don't believe it's completely validated, and I agree, it's more recent and all of that. So why don't you do directly adenosine?
Yeah. When you pass the pressure wire down, it's just toggling on the screen and you get the RFR. It's you can get the you get the PDPA and then just give the that's not a bad thing to do if you're just going to do the FFR.
I usually solve the problem doing imaging, I do imaging and
Yeah, I agree.
and I'm happy. Then there
I
is,
agree.
as you said before, a gray zone where maybe you can
So she
add
kind of
some
fitted in that gray zone. And
yeah.
when I
Yeah,
did the FFR pullback, what you see there is at the osteoproximal left main, you get this jump. So this is the pullback gradient, which is quite nice to demonstrate.
yeah, nice.
And then so we had a discussion, Prof. I know you're a Ferrari man, so this photo might
I don't
you
appreciate
might
this.
not appreciate that, but I think we had a discussion with our surgeons, and for isolated osteal left main disease, remember that it's not the mighty cabbage versus the awesome PCI. It's a shared decision making for the best therapeutic option for the patient. Her syntax score suggested either was viable, but decided to proceed with PCI. So use this sepal wire technique. Gregor sort of published this earlier this year. He kind of labeled it the Walpo technique, or wire in the aorta for localization and protection of the osteum.
But this is a quite old
Yeah,
technique.
it's
So
basically just a sepal wire. Yeah, so you can see
Yeah,
this.
wire actually. You're right.
Yeah, so
nothing new under the
nothing
sun.
new, but he called it a fancy name, you see.
Yeah, that's exactly.
So I just did a bit of scoring there. I like to, for osteal lesions, I like to use either cutting or scoring balloon, just to make sure we get good, adequate stent expansion.
Yeah,
And then a single Megatron stent, and just from the osteal to mid shaft.
nice.
And the final areas were quite good. And so just some take-home messages. There's considerable randomized data that exists supporting physiology-guided revascularization in epicardial vessels, but unfortunately, the evidence base largely excludes left main disease. The complex anatomy and physiology of left main lesions make FFR assessment more challenging, particularly if you've got downstream serial stenosis interplay. And the use of FFR and IFR pullback maneuvers with aid from intravascular imaging will provide diagnostic clarity in majority of scenarios, and always put the data in context with the patient at the center of any decision-making process. Thank you.
Thank you, Bharat.
Hopefully
As
not too
usual,
long.
very nicely. No,
Very
thank
nice,
you.
brother. Thank you.
Very nicely depicted, starting from a case. You touched a lot of interesting topics, and you were also synthetic, so you did a great job, in my opinion. The only thing I'm asking is, I had to jump to another meeting, and luckily I had my iPhone, so I kept it on the background. I hope that they didn't ask me anything in the other one. But my question is, I don't know if you went through that. Did you mention OCT for left main?
No, so I didn't go into OCT. I sort of focused mostly on IVUS, because there is emerging trend towards using OCT for left main. It is a bit more challenging in the sense that to get good coaxial guide engagement.
Well, but that's not an issue, It's with some
I think
tips and tricks, it's easy.
osteo is hard, isn't it? Like I don't know. Can you
Now,
get? Can you?
osteal is 10% of the left main. It's not an issue,
Yeah,
If you have
yeah.
a mid left main and
I actually
the
showed
left
your
main
slide. This was from you.
10%. What?
This slide
Oh,
is
this
from
one from
your
my book.
Yeah, from your book.
No, but not for me. I think that so far OCT for I would like to have your opinion. This is just
Yeah.
my thought. It's not low or whatever or solid evidence, but so far the data that we have with OCT is more solid than the one that we have with physiology for left main assessment. So we published ROC 1 on the feasibility of OCT versus standard of care, ROC 2 comparing OCT to IVUS to angiography with a clinical outcome, and we presented this year ROC 3 at TCT with Wojciech and other friends on a comparison between OCT-based angioplasty of the left main versus CABG. And there are also other studies. The group of Gemelli with the group of Gemelli with Burzotta has done some feasibility studies. Now there are sub-analysis of large trials presented last year. So now OCT for distal left main, is something that's my first choice. That's my first choice, unless the patient has other reasons for not doing OCT, renal insufficiency, whatever. My first choice now is doing OCT. So I think that it is worth mentioning that with some tips and tricks, for example, using a guide extension, as you said, as you were mentioning, coaxiality, having a good coaxiality of the guiding catheter, you have really high quality images for the distal left main, which can lead you to do a good angioplasty with good clinical outcome, as we have shown in these studies.
Bharat, can you hear me?
Yeah, I can, Sandeep.
Yeah, it's a great lecture. Thank you for that. I've got two comments. One is that when you have intermediate stenosis, yes, you can use IFR, FFR, whatever. But I think we also have to take into consideration the plaque burden, because if you have a plaque burden of more than 70%, I tend to go with patient symptomatic. I just PCI it, because you could have a huge positive remodel left main with a high plaque burden, even if your MLA is more than 6. But if you take the plaque burden, if it's more than 70%, that's probably enough if patient has symptoms to treat it. The other important point is that left main spasm is not as common as the other right coronary, but something you have to bear in mind, because we showed 2 cases of the PCR a few years ago where patient had a bypass based on angiography, and when he came back a few years later, there was absolutely no stenosis in the left main, so both the grafts went down. So I think it's worth giving some nitrates and make sure this is not spasm.
Yeah, that's a very good point.
That's.
Any other question or comment from Pakas, Jacinth, Sarah, Sylvia?
None from me. It was a bit tricky for me to understand a bit, because I'm not really familiar with the physiology yet, OCTs and IVUS, but I'm trying my best to understand through the presentation. And I find it good and interesting whenever, for example, Dr. Baharat started with physiology and started with cases. So I think it is more familiar that way for me.
Thank you, Dr. Barat, for your nice presentation.
Giovanni.
I definitely believe that being not an expert operator, I believe for the reason that based also on your presentation, that I definitely will prefer IVUS, just because also the assessment of the osteal lesion, especially of the last lesion, even if they are not the majority, but the pressure curves are a little bit more difficult to assess, to be sure that you have not a pressure drift, and that you have had a well done assessment, and for the reason just because I will need IVUS to perform PCI. I think that there is no reason for physiology. I love physiology. My center is centered on physiology, post PCI assessment of the result and stuff like that. But I think that also IVUS as in this case is could be the best option. And also I believe that the studies are based on an MLA more than 60 millimeters square. That if we think about the diameter with a 6 millimeter square MLA, we are referring to 2.76 millimeters of diameter. That is something that is crazy for a left main, no? So yeah, but it was super nice and well done. So congratulations for your presentation, for this recap.
And Irfan,
Thank you.
Irfan, in your country, how is the trade-off between cabbage and PCI for the left main so far? I don't know if you hear me, Irfan. You're muted now.
Hello?
Yeah.
Yeah. Can you tell me again?
Yes. Yeah, you can hear you. So I wanted to ask you, which is the trade-off between cabbage and PCI for this left main in your country so far?
Yeah. Here in Pakistan, we actually have very long list of cabbages. So for that's why most of the cardiologists prefer PCI when it's visible, when it's two vessel disease or not more than that, and are only left main vessel involved. So mostly they goes for PCI. But here we actually have no OCT and our IVS like that. So that's why we stuck here.
Okay, and I see that also Wojciech joined. Probably he was engaged in a complex CTO, or he was also stimulated by my message. Hi Wojciech, how are you doing? Yeah, no, we cannot hear you. Did you remove the gloves?
Hello. Sorry, I was doing the. So
nice to see you.
Nice to see you all. Sorry for delay. However, I had procedure. Congratulations the presentation. And how does it going in our country, in Poland, about left main? All of left main, mostly of left main, we are doing the consultation with our friends cardiac surgeons. So to have backup in those cases. However, in low risk patients, so when we have, for example, only left main disease with lower or moderate syntax score, we do PCI. So this is a regular procedure in my cath lab. So, however, to be honest, last week I had the case very calcified left main, distal part of left main. I think it was calcified noodle, and I've low syntax score, but calcified noodle, and I decide to transfer those patients to the cabbage. This is also quite interesting point. When we have calcified noodle in left main, the 80% of the calcified lesion in left main distal part. What is your practice? Only one lesion. Very calcified lesion, left main, and patients 67 years old.
Yeah.
80% stenosis in the distal part of the left main, calcified noodle.
Yeah, I think Wojciech, you are wise. I mean, if the patient doesn't have a specific comorbidity which could hamper the feasibility or the safety of a cabbage, if this patient only has this isolated disease, I think that it can be wise to send him to a good surgeon, because as you I think you intend to say, is calcified nodule is our worst enemy. We know that, and dealing with that is not easy. I have to say that recently I managed 3 or 4 of them in the last 2 months here, distal left main or ostial circ, because very often I can see that calcified nodules are also in the ostial circle, well, at least angiographically. When you do imaging, you see that they are actually, from the anatomical point of view, protruding into the left main.
Yeah.
But anyhow, these are really complex lesions to deal with. So, but these patients that I did were refused by the cardiac surgeon due to age, comorbidity, all of that. So in all of these patients, I did either ROTA or CSI. If you don't ablate the calcified nodule, you're not going to have any chance of having a good stent expansion.